Well, good evening and welcome to our ESRA industry-sponsored webinar. My name is Jeff Gadsden, and I'll be one of the speakers and the moderator tonight for this program. It's a great pleasure to be here with my two co-hosts, who I'll introduce in a second. But first, I wanted to thank Pajunk for sponsoring tonight's webinar. And it's entitled Ultrasound-guided Fascial Plane Blocks, Clinical Best Practice. And if you're like me, these are things that have really grown in your practice in the last several years. And tonight we'll be hearing from three of us about how we best implement some of these techniques in our everyday clinical practice. So with me is Renee Vandenbroek, who's an anesthesiologist from Catheters Hospital in Eindhoven in the Netherlands, where she specializes in both cardiac and regional anesthesiology, and has a research interest in fascial plane blocks, especially PECS and ESP. And we also have Alexander Brederode, who is a South African trained anesthesiologist, but now practices in Munich in Germany, where he's been for 17 years and is also an expert in regional anesthesia techniques. And there we go. Sorry, there's our faculty, and is going to speak to us tonight about PECS and Supratus blocks. And Renee will talk to us about ESP blocks. I come from Durham, at Duke University in the US, and I'll be talking tonight about Rectus sheath blocks, which is one of my favorite blocks. This is a non-CME webinar. Please use the Q&A feature for questions. We're going to leave lots of time for questions at the end. And there is a certificate of attendance available. Just email that email address and you'll get your certificate. The webinar is being recorded and it will be available afterwards on the YouTube channel. It takes a few days to get up there, but you should find it if you wanted to go back and review some of the information. And none of us have relevant financial disclosures for this webinar. Okay, so I'm going to lead things off and talk about Rectus sheath blocks. And this is fast become one of my favorite fascial plane blocks to do, and it's really got some interesting anatomy. So if you think about a cross section of the abdominal wall, here we have our three tap muscles on the right hand side, so external oblique, internal oblique, and transversus. And the fascial coverings of those three muscles come together and then envelop that rectus abdominis muscle. Now the nerves come through, as we know, through that tap plane and then jump into that fascial sheath that envelops the rectus muscle before traveling up and through to supply the soft tissue and skin of the midline of the abdomen. And this gives us an opportunity to put a needle on some local anesthetic within the rectus sheath and capture that nerve as it goes. There are some vessels in there, so I always tell my residents, be careful, use the color Doppler function to make sure that your needle path isn't going to go through or nearby some of the sometimes substantial vessels like the inferior epigastric artery. And there's kind of a illustration of our goals. Now, the Dutch are really, really good at anatomy. It's so much so that here in Amsterdam, as you see this picture, they've actually made their trolley tracks mirror exactly the fascial coverings of those layers we just talked about. So you can see we have the external oblique, internal oblique, and transversus muscles. The trolley tracks come together and then expand again to encircle and ensheath the rectus abdominis muscle. And using this analogy, we're going to see on the ultrasound image two distinct trolley tracks underneath the rectus muscle on the deep surface. This is the posterior rectus sheath. And the goal of this block is to get local anesthetic here, just between the posterior rectus sheath and the muscle itself. Not between the trolley tracks. It's when I first started doing this, I thought, oh, I have to get in between the tracks, but it's unnecessary. You just want to peel that muscle off those two white lines. And our goal here is to layer local anesthetic underneath that rectus muscle And that potential space that we're targeting is continuous from the xiphoid down to the pubis. So you can put a needle in anywhere along that rectus muscle and target certain areas, from as high north as T6 down to T12 or even L1. So that's kind of the schematic or the model that we're going for. Here's my standard probe positions, just off the midline over the rectus muscle. I'll often do this block at the end of the case when the dressing is already on the midline of the abdomen, and there's still enough rectus muscle laterally that I can sneak a probe in there and get the needle in from the lateral side. And here's the sonoanatomy. So you see we have this lens or boat-shaped muscle that that is the rectus. There's some superficial subcutaneous fat, and then below the muscle we see that double white line of that posterior rectus sheath. And there it is there. It's one of those reliable sonographic landmarks you see again and again in patients, even when they're fairly big, like a lot of my patients are here in the US. So here's a video. We'll see, again, a substantial layer of subcutaneous fat. Then we have our rectus muscle itself. There's our dual trolley tracks underneath the posterior rectus sheath. And the needle is going to come in from the lateral aspect. And so here we go. We can see the needle enter the rectus muscle. And at this point, I want to do a little test injection just with some saline as I approach the posterior rectus sheath, just to make sure I haven't gone too far. So that first injection, that's intramuscular. You can see those muscle fibers peeling apart. And advance a little bit more. And oftentimes there's a little give, a little oomph. And then that final injection looks beautiful. And this is my favorite part of this block. It opens up like butter. It just lifts that muscle up. I don't find that I'm fighting with this block in the same way that I fight with a tap block sometimes to get just the right plane and intramuscular on either side. But this one usually is an easy go. In terms of volumes, I started doing this with 20 mils each on either side of the abdomen, either side of the umbilicus, and you seem to get a decent spread up and down. So maybe 2 layers up, 2 levels up, 2 levels down, covering a nice peri-umbilical area. If I was after something more extensive, like a midline laparotomy that went from stem to stern, I would typically do 20, 20, 20, 20 to get that full spread and hopefully get something like that. And that worked great. It worked fine. It's a lot of pokes though. So it's 4 different injections. And of course, the surgeon's tapping their foot. They want to get moving and so forth. We actually did some cadaver work looking at the distribution of dye. You see the green dye and the blue dye on either side of this rectus sheath. The rectus has been removed, and that's the posterior rectus sheath where there. And you can see it's extensive. And this was with 30 mils on either side of the umbilicus. So now what I do, I'll use, if I'm after the full thing, I'll do 30 mils, just either side of the umbilicus. And that gets me most of the way up to almost the chest, the xiphoid process down to the pubis. Now it's worth noting that there's a defect that the posterior rectus sheath stops at the arcuate line, which is some distance between the umbilicus and the pubis, usually about 1/3 of the way down. And so if you try to image the rectus muscle close to the pubic bone, you won't see that posterior rectus sheath. And probably it's worthwhile not going too far south from the umbilicus. So that's a reasonable approach. I think if we were to go down here, you've got 1 fewer layers between your needle tip and the preperitoneal fat and peritoneum. So we tend to stay fairly close to the umbilicus and count on that spread to get you the whole way. It'll spread down even with the absence of that posterior rectus sheath. Yeah, so stay more like there. Now, how well do these things work? Surprisingly well. Here, I'm going to just show you just 2 studies. This is one out of the UK looking at thoracic epidural analgesia, which, come on, I think a lot of us consider that kind of the gold standard for abdominal analgesia, compared to continuous rectus sheath catheters. And you see that the pain scores, the time to mobilize, and the hospital length of stay were equivalent between the two groups, which is pretty impressive. We don't think that we get visceral pain with this. These are somatic blocks. And so that it's hard for me to sort of reconcile how I grew up with thoracic epidurals, knowing that they get somatic and visceral pain versus just this technique, which gets you only somatic pain. And I think part of the answer to that, and I don't know the answer, I'm guessing here now, is the fact that some epidurals just end up being not so great. So over time, if you end up with, you know, an epidural that you have to troubleshoot and it's patchy and there's inadequate spread to certain parts, maybe the rectus sheath is a more consistent, if not perfect, technique. There's another more recent study, this one out of India, again, showing pretty much exactly the same thing for midline incision laparotomies. No difference in pain score with coughing or with rest, and no difference in opioid consumption over that first 2 postoperative days. So again, it's not better than an epidural, but if it's at least close to a thoracic epidural, I think it's a total win because it's easy to do. We use it for a lot of our trauma laparotomies and exploratory laparotomies, things that are urgent that we don't have time to put in an epidural, or where there's a coagulopathy in a trauma patient that precludes the use of epidural analgesia. But more and more, we're electing to do this anyway in our ERAS pathways, as opposed to, 5-10 years ago, we were doing a lot more epidurals, and this has become our block for midline stuff. We get called into the operating room a lot when the surgical colleagues have converted from a laparoscopic to a midline technique, and we'll do rescue rectus sheath blocks. Cystectomy, it's part of our protocol for that. A lot of lower abdominal colorectal surgery, it's in the midline. And then we've made really good use of these high up near the xiphoid process for those epigastric chest tubes after cardiothoracic surgery. That's been a real win in terms of analgesia afterwards. So when I'm thinking about what place a block might have in my practice, I always want to think about, is it versatile? Can I use it for several different things, or is it just a one-trick pony? Is it safe? Am I possibly going to cause harm? And this is an example of a block that I think is a very, very safe. There's a vessel to look out for, but there's not, and as long as you have good control of your needle, there's not a lot of tiger territory you can end up in. And is it simple? Is it scalable? Is this a block that only my friends who are regional experts can do? Or can I teach my entire anesthetic department how to do this block and do it effectively? And this is, again, this is a win on all 3 of these areas. So with that, I'll stop talking and I'll turn it over to Renee to take us through the next part.
Thank you, Jeff.
We'll do questions at the end. And please remember to put your questions in the Q&A. We'll have a question and answer session at the end.
I will start to share my screen right now. Can you see it properly? Jeff, can you maybe respond?
Yep, looks great.
Okay, thank you. Well, my name is Renee, and I will talk to you about ESP block. That's what I study, that's what I like. So I will tell you something about what we do with ESP block, how it works, and why we use it the way we use it. Let me see. Yes, perfect. So the ESP blocks is usually performed by depositing local anesthetics in the fascial plane deep to the erector spinae muscles, and the needle tip goes to the transverse process of the vertebrae. The patient is in sitting, supine, or lateral position. And you start scanning with your ultrasound probe here in the midline. If you scan from medial to lateral, you will first see the spinous process. You move the probe more laterally, you will find the transverse process. Just a little more lateral, you will see a small discontinuation, and then the rib with the pleura below. I will show you this in a video. So you will start medially in the midline. You will see here the spinous process. Laterally, there you will find the transverse process. A small discontinuation is right there. And then you'll see the rib with the pleura. In our experience, this block is easy because the anatomy is simple. You can do it quickly. And when you put the patient to sleep first, there's obviously no patient discomfort. So how does it work? Well, classic regional anesthesia is focused on targeting a single nerve or plexus, but fascial plane blocks are a different class of regional anesthesia techniques because they target a plane or compartment between two layers of fascia, and there's no attempt to locate the individual nerves. And the way this works is generally believed by bulk flow and diffusion, but also through some systemic absorption. The local anesthetic blocks the dorsal and sometimes the ventral parts of the spinal nerve. And because the fibers of the erector spinae muscles are vertically orientated, the distribution of the local anesthetic is also in a vertical pattern. There are two papers I would like to advise you to read. They're written by Chin and published in the July issue of Regional Anesthesia and Pain Medicine. And these articles will teach you that what I just told you about how ESP block works is only a very narrow concept of how this works. It neglects the complexity of the fascial system. It tells you that the porosity of the connective tissue is very important and plays a role in the distribution of the local anesthetics. And these articles will also explain to you why there is paravertebral spread and why there is a patchy and variable nature of the cutaneous sensory block. So read them. This is just how it works. Now we will continue with the why. I will tell you something about different indications, about the level of puncture, the volume and the dose of local anesthetic you can use, and the material that we use. So ESP block is used for a lot of different indications, from patients with rib fractures to patients undergoing open cholecystectomy. My focus in research is on lumbar spine surgery and thoracoscopic surgery. So I'll talk you through the existing evidence in literature on these two topics. So in spine surgery, we did a small retrospective surgery on patients undergoing lumbar fusion surgery. We did an ESP block after induction. We put the patients in supine position. We scanned with an ultrasound probe with a curved probe at T12. And then we placed 20 milliliters of ropivacaine bilaterally. And we saw that the patients with ESP block had less pain, needed less IV morphine on the ward, and they had a shorter length of hospital stay. While this is only a retrospective study, there are several RCTs showing single shot ESP block reduces pain and reduces opioid dose post-operatively. And these are 3 studies that are published in the last 2 years, comparing ESP block to a control group or to placebo group. There's also meta-analysis published this year. And this table shows the total opioid consumption in the first 24 hours after surgery. And as you can see in these 800 something patients and 12 studies, that patients with ESP block in lumbar spine surgery had less pain, needed less opioids, and also had less postoperative nausea and vomiting. So far on spine surgery. In thoracoscopic surgery, there are lots of case series. When we look at RCTs, there are several. There are some RCTs who use a single shot ESP block. in video-assisted thoracoscopic surgery. There are 2 studies comparing ESP block to control groups, and they show that patients have less opioid need, have less pain, less nausea and vomiting, and less itching. There are 2 studies published last year that compare single-shot ESP block to a placebo group. They show higher quality of recovery, and that these patients also have less pain and less emergent agitation. Maybe you are not really interested in studies comparing ESP block to a control group or to a placebo, but maybe you are interested in what the ESP block use compares to the technique that you are already using, so paravertebral or intercostal block. There are a few studies that compare those 2. In one from Durham in 2020, this is published. They compared 3 groups, ESP block to paravertebral to intercostal, and they showed that paravertebral gave the best analgesia. But another study from the same year by Zhao showed that ESP block and paravertebral are compared equally. So maybe we need a little more studies to give us a definite answer if there is a difference, or maybe they are equal. Maybe you are not really interested in single shot ESP block because what you do now is maybe a continuous epidural technique. So maybe you are more interested in what is the effect of a continuous ESP block. There are 2 studies on this topic. One from this year, from Piskin, and that compared continuous ESP block to a control group. But also a study from Regional Anesthesia and Pain Medicine in 2019 already, comparing continuous ESP to continuous paravertebral, and that showed that it's about the same. Currently, we are undertaking a study comparing continuous ESP block to epidural, which in the Netherlands is the technique most chosen for thoracoscopic video surgery. And I hope I can share the results in a year from now. We are still working on it. So now you know something about indications. What level are you going to perform the ESP block? In thoracic surgery, video-assisted thoracoscopic surgery, Dick Kasai summarized a local anesthetic spread in this table. They showed that 20 milliliters of dye or local anesthetic in cadavers and actual patients covers about 3 to 9 dermatomes. So we usually perform the ESP block at T4, and this covers the dermatomes in which the videoscopic ports are placed and where the thoracic drain is postoperably. In spine surgery, maybe your orthopedic or neurosurgeon will ask you, well, what about infection, and will there maybe be motor blockade? Well, there are no cases described where postoperative infection is linked to the ESP block, but for the comfort of the surgeon and for the success of implementation, we decided to perform the ESP block in lumbar spine surgery at T12, which is above the level of surgery. And a study by Zhang showed that there is extensive sensory block when you perform an ESP at T12. They showed a sensory block from T8 to L5, so that's enough. And how about motor blockade? Well, there's conflicting evidence from studies. Some show that there is ventral spread. Some show that there's no ventral spread. So literature just has no definite answer yet. In clinical practice, we performed the ESP block at T12, and we have not seen any motor block yet in about 2 years of doing this. But evidence from the literature is not conclusive on that topic. The next one. So what volume and which dose of local anesthetic can you use? In spine surgery, a cadaver study by Azevedo showed that there is dorsal spread of dye when you use 20 milliliters. And they showed that there's also ventral spread when you use 30 or 40 milliliters. So maybe anterior spread is volume dependent. When you read articles on ESP block in spine surgery, there are a lot of different volumes used, a lot of different dosages as well, from 10 to 30 milliliters bilaterally, and from 0.25 to 0.5 bupivacaine, and also ropivacaine. So there's no definite answer yet. In thoracic surgery, there's also very little evidence. In patients after radical mastectomy, which is a different kind of surgery, ESP block with a higher concentration of bupivacaine showed that patients needed less opioids, so it worked somewhat better. But when you look at other fascial plane blocks, you cannot generalize this conclusion. So for instance, TAP block in inguinal hernia repair showed no difference between the two dosages of bupivacaine. In the literature, in studies on thoracic ESP block, there are, just as in spine surgery, lots of different volumes used and different concentrations. So what is the best? I don't know yet. Another question that arises is, should you use intermittent boluses or continuous infusion if you use a catheter technique? There are no studies that compare this, so there's no answer yet. What we do in spine surgery, we use 20 milliliters of ropivacaine 0.5% bilaterally. And in thoracic surgery, we give a bolus of 40 milliliters of ropivacaine 0.5%. And then on the ward, we start a perfusion of bupivacaine with a lower concentration. And we ask the nurse to give a bolus every 3 hours. The material that we use, well, basically you can use whatever is most comfortable to you. For single shot technique, you can use a short bevel needle. You can also use a TUI needle, which is bigger and somewhat more stiff. For a catheter technique, you can either use the Pajunk set, which is on the left, or an epidural set. We remove the stylet and we attach an IV line so that an assistant can inject the local anesthetics, and you have your one hand on the needle and another on the ultrasound probe. So this is in an awake patient model. And usually in spine surgery and video-assisted thoracoscopic surgery, we have the patient supine and or laterally, but under general anesthesia. The ultrasound probe of choice is dependent on the size of the patient, really. Linear probes have higher frequency and poor penetration, but good resolution. So it's usually suitable for thoracic ESP block and lumbar in very thin patients. Curved probes, they have a lower frequency and a greater depth of penetration, so they are more suitable for obese patients. As you can see it here in the two pictures, this is ESP block in a somewhat obese patient. Lumbar, on the right side, you can see the bony structures, but on the left side, you cannot see anything. So just now we have discussed the how and why of the ESP block. Lots of questions are still unanswered. So more research is needed. I would like to know more about the quality of recovery with ESP block instead of only pain scores. I would like to know the difference in for the patient and when you use single shot or the catheter technique. I would like to know an answer to, if I use a catheter technique, should I use intermittent boluses or continuous infusion? I would like to know what is the best dosage and volume. And we don't know yet what this does for chronic pain, or in really, really large numbers, are there very uncommon side effects or risks that we don't know about? So lots to discover. So I would like to thank everybody in our research team, and thank you for your attention. And then I would like to give the speaking back to you, Jeff, or to Alexander.
Well, thank you so much, Renee. That was excellent. Looking for lots of questions, so be prepared. And now we'll turn our attention over to Alexander, who's coming at us from his hotel room in Egypt.
Right, I'm just loading up. I hope you can hear me. Just give me a word if that's all right.
Yeah, looks great and sounds great.
You see? Okay.
All good. Yeah.
Good. Thanks, Jeff, for the introduction. I'm talking on serratus and PECS, or anterior blocks for the anterior chest wall, and specifically looking at oncological breast surgery. Otherwise, it's too broad a topic. These blocks have got lots of other new names, but for simplicity, I'm going to stick to serratus and PECS too. So I'm talking a little bit about a lot. So I'm covering a vast amount of ground, but not in very great depth because of the time limit. So first of all, you have to know that you've got to think about how do you think fascial plane blocks work, philosophy of regional anesthesia. So I think we're trying to get the local anesthetic near to the nerves, block nerves, get pain reduction. But there are other methods that these blocks may be working on, and that will change where you inject. And so you have to understand that what I'm talking about is trying to block the nerves. So I want to know where they are, and then get local anesthetic in the same spot and switch them off. So that means neuroanatomical relations of the chest wall, and where am I going to get to these nerves, and what are the practical implications for my technique. Now, that's not just theoretical, because the evidence, if you don't understand the neuroanatomic relationships, the evidence can be very difficult to interpret. So you need to know what blocks can you compare to other blocks, where they're going to work, what surgery is going to work with which block. We'll be doing some tips and tricks as we go along, and we might have time to see if mono techniques work for breast surgery without general anesthesia, and what else we can use it for. So breast innervation, 3 groups of nerves going down there. The main group is the intercostal innervation, which is segmental, right? So we're looking at intercostal nerves T2 to T6, and they're coming anteriorly, and they're giving off 2 branches, the lateral and the anterior intercostal perforating cutaneous branches. Now that's a mouthful, so I'm going to shorten that to lateral and anterior perforators, and it's known as the segmental innervation of the anterior chest wall. There are 2 other groups of nerves, the supraclavicular nerve C3, C4, and that's got a small area of cover, and then the muscle innervation of the anterior chest through the Pec Major, Pec Minor muscles with medial and lateral pectoral nerves, which are coming out of the brachial plexus. So we've got mainly segmental, we've got a little bit of brachial plexus, and we've got a tiny bit of superficial cervical plexus. Now the axilla is exactly the opposite. So here we've got predominantly brachial plexus innervation and a small amount of segmental innervation. Probably the most important nerve is the long thoracic nerve, which is doing the serratus anterior muscle innervation, which is going to be lying medial, and that's where the surgeons are going to be entering the axilla if they're doing lymph node dissection. The others are thoracodorsal, subscapular nerves, and then the base and this of the axilla, the skin and the fascia is the intercostal brachial branches of T2 predominantly, and a bit of T3. And they're going to mix with some of the medial cord branches of the upper arm. Now, these branches, the intercostal brachial, they've just got a special name because they're going into the arm, but they're actually part of the lateral perforators, right? So the lateral perforators give off anterior and posterior branches. And this is an article from Chin. I think Renee also mentioned him. He did a couple of articles on these fascial plane blocks, which are really good. And here you see in green and red the intercostal or segmental innervation with anterior in red and green lateral perforators. And the lateral perforators have got a posterior and an anterior branch. You can see that. Now, actually, anatomically, the posterior branches are much more dominant than the anterior branches. You don't see that here. And the brachial plexus components are your medial pectoral nerve, your lateral pectoral nerve in black, and you've got your long thoracic nerve in orange, and intercostal brachial nerves in blue, mixing with your plexus nerves for the medial arm. The purple is supraclavicular nerves. I think that's a bit of overrepresented here, but that's a nice pictorial depiction of the innervation. Now, what else could it look like? It could look like this. So here we see a division of labor between the anterior and the lateral perforators. You see this black line going across. So the superior part of the anterior thoracic wall is more dominantly innervated by, and this is just the cutaneous innervation, by the anterior perforators. And if you go down on the breast, inferiorly, you see that the lateral branches, the lateral perforators with their anterior component are doing much more of the work. So there's a tangential demarcation across the breast tissue, which isn't always so obvious from the depiction previously. Now, this is a PIP block. So a PIP is a parasternal intercostal plane block. So we're doing the anterior perforators at T3, and we're doing a deep PIP. So you can do a superficial or a deep one. This is a deep one. And the idea behind this block was to get in 10 mils really quickly with high pressure and get some segmental spread to other segments. And it's being done from medial to lateral. You can see the needle coming onto the transverse thoracic muscle, which is a small muscle, and the red vessel is the internal thoracic artery, which you are not allowed to hit because it will just not stop bleeding. There's no tissue to build up pressure to stop the bleeding there. So don't always depict that nerve with Doppler, or you'll see it pulsating and avoid it. You have to do this from medial to lateral, I'm afraid, in my opinion, because otherwise you're sticking a needle into bony shadow. So you can see on the right base of the picture, there's bony shadow from the sternum, and you won't see your needle tip as you go into the shadow, and you will do some damage there. So always from medial to lateral. Superior inferiorly is also not a good idea because you've got bony shadow from the next rib. Right, so this is what goes numb. You can see a segmental spread, and this is no superior, inferior spread to other segments, and it goes beyond the midline, as we saw earlier in the depiction, quite extensively to the lateral edge of the pec major muscle. Now, if you do the same block, so this is a PIP superficial, this is what goes numb, and you do that in plane from inferior to superior, and you can do that nicely under the pectoral pec major muscle. It's not very difficult, and you can use an 8 centimeter, 10 centimeter needle and hydrodissect up, and you get quite extensive spread, which you cannot do with a deep PIP block because the ribs provide a gutter kind of effect, so that the local anesthetic cannot get out of the gutter produced by the ribs, and it will spread only medially and laterally, but not superior inferiorly. Now, it's a bit more complicated because the dark blue area is that area of the skin that went really numb. So that's surgical anesthesia, and the dotted area is only hypoesthesia, and you couldn't operate there. So there's something else going on here. And what's also a bit disconcerting is that the line of demarcation is in exactly the opposite direction as what we saw earlier. Okay, that's food for thought. Here we have to talk about fascia, and I mean, we're talking about fascial plane blocks, and if you don't understand the fascias, you can't really adapt your blocks to try and achieve the results that you are aiming for. Now, this is a very important fascia. It's called the clavipectoral fascia. It's got some other names in German, as you can see, and it's essentially going from the costal margin, and it's going out, it's going out laterally from the clavicle downwards, across and over and under the pec minor muscle. So it envelops this muscle. It's exactly like Jeff's block with the erector sheath. So this muscle is enveloped by the fascia. And as you go laterally, you'll see the fascia continue to the humerus. That's the suspensory ligament, but it's divided into two. And that's what you don't see in this picture. It's actually reflecting downwards over the serratus anterior muscle at the same time. So it's somewhere behind pec minor. It's dividing into two, and it's separating everything that you're doing with a PEC 1 block deep to PEC major from going anywhere near the brachial plexus. It can't get really to medial pectoral nerve. It cannot get to the anterior perforators, the anterior part of the lateral perforators, and so it's a single shot trick, which is going to get the lateral pectoral nerve, and maybe, if you're lucky, some of the anterior perforators. So having a look at this fascia, this is now the outer edge of the pec major, pec minor muscles. Left is lateral. We've got some labels in here. We've got pec major, pec minor. This is the third rib, and you can see serratus anterior becoming thicker as you go more posterior. And the fascia splits here. So this is the clavipectoral fascia that's enveloping pec minor, and it's going out laterally, and it divides into two. The superficial fascia is the suspensory ligament, and the lower version is covering serratus anterior, And now the question is, what happens to your local anesthetic when you inject it in a PEC 1 and a PEC 2 block? The green here is now axillary fat tissue. This is not where you want your local anesthetic to spread to at all, because it will distort the anatomy for your surgeon and he will not be your best friend anymore. The PEC major, PECS 1 block, you can see the blue demarcation, that's where the local should go, and the PEC 2 block should go deep to PEC minor, and you can see where it should go. And if you're going to combine this with a serratus anterior block, I recommend you do it deep to serratus anterior muscle and not superficial at this level because of the risk of spreading into the axilla. Now, this is what certainly can and does happen. If this fascia isn't complete at its lateral edge as it splits into two, then the possibilities with the PECS 2 block, you get local anesthetic spreading out into the axillary fat tissue. So you can't see this double layer here, but if we have a view on the other side, you can see a double fascia now for the deep layer of the clavipectoral fascia as it divides into two layers, one staying underneath Pec Minor, the other going down into the axilla over serratus anterior. You can see a red artery, that's probably the lateral thoracic artery, and the red arrows are showing you if you go deep here to Pec Minor and you get this layer with a local anesthetic spread, you're spreading it into the axilla. Now, this is not important if there's no axillary surgery, that doesn't matter. But if the surgeon's going to take out lymph nodes, then they may well complain to you that they can't see, there's no anatomy discernible anymore due to disruption with local anesthetic. So he has a PECS block. So I've done a PECS block that isn't the best one because you learn more from the imperfect shots at these blocks. So you can see a surrogate marker here, an artery. You can see the needle coming in. It's opening up various fascias between Pec Minor and Pec Major and going to deep now, and it'll lift up in the muscle of Pec Minor, and then it'll come back and it's going to go intramuscularly into Pec Major there, not quite yet, but now. So that's again in the wrong plane, and then there are multiple planes here to choose from. It's not that easy. Out here, there's a surrogate marker, which you can see the local anesthetic now going towards. So I just want to show you that it's not technically that easy to always choose exactly the right plane, and there are multiple planes, and they all look a bit similar, and only one of them is going to be right. Okay, so yeah, we've got our volunteer. We've added a PECS block to this poor soul, and he's now had a PECS 1 and a PECS 2 with the traditional volumes of 10 and 20 mils. We've got the original T3 anterior perforator still numb, and this is what goes numb in addition. So what we can see here is that there are some anterior branches of the lateral perforators that have gone cutaneous branches that have gone numb, and nothing going posterior. So no intercostal brachial, no T3, no T4, nothing going posterior is being anesthetized, and there's limited cutaneous sensory loss. Now, I have to immediately add to that and say the sensory loss you get with these blocks in the anterior chest wall does not correlate well to morphine sparing effect. So you cannot say because something's gone numb, it's going to work well. And conversely, you can't say because virtually no skin has gone numb, like in this case, we're expecting poor results. Unfortunately, it's a bit more complicated. So if we add a SAP T3 block, so this is serratus anterior plane, and remember I said you've got to do these deep because otherwise you might get spread superficial to the clavipectoral fascia into the axilla. If you do these deep to the muscle, so you use the rib as a backstop, and it's very similar to Renee's Erector Spinae. You lift the muscle up off the bone, and you get a nice anterior and posterior component of the lateral perforator here. You can see this is T3. It's going into a small part of the arm, but it's not doing the axillary base. So it's not T2. And what's also striking, this is 10 mils of local anesthetic on the third rib, and you don't get much superior inferior spread. You might have a bit of T4 here because we've sort of got some spread over the nipple height. So we might have T3 and T4, but we haven't got T2 because then the intercostal brachial will be numb. This is something about the spread, which we discuss later if there's time. Now we've added a T6 serratus anterior plane block, and this is a deep block. The D is for deep, right? So it's done in the mid axillary line, and it's again 10 mils on the rib, lift up the muscle, and you get a single segment going numb. So this is just T6. It's nothing else. It's not spreading to T5. There's still a gap between T4 and T6. And you get quite extensive anterior anesthesia, which is what we're expecting. We said the lower part of the chest is innervated more dominantly by the lateral perforators, and the superior part of the anterior chest is more by the anterior perforators. So this sort of fits to our plan, and you get nice anterior posterior spread. So what does the evidence show? Prospect has summarized all of that hard work for us, and they've come up with some really good guidelines, and they've reviewed them because of these new blocks coming out. So they've only, I think the previous review was 2016, and they've had to do it again because of the blocks. So it's divided into minor, major surgery. Minor surgery doesn't get any blocks, it gets local infiltration and a multimodal approach. If you're having major breast surgery, so large excisions, reconstructions, modified radical mastectomies, then you do a paravertable block, and that's got grade A evidence. If you cannot do a paravertebral block, then you do a PECS block, and PECS block has got grade A evidence. So that's really good. And you get about 40% reduction in opiate consumption for a paravertebral and about 35 to 40% for a PECS block. And that's not only statistically significant, but probably very clinically significant as well. Right, so they looked at 53 randomized controlled trials. They had 9 meta-analyses included, grade A evidence, but the paravertebral blocks lasted longer than the PECS block. So at 18 hours, the PECS would start to wane and the paravertebral block would still give some benefit, but multiple injections needed for your paravertebral block. So again, we're not using a single technique, we're doing a multiple injection technique to get the coverage from T2 to T6. That works better than a single injection. You can do a single injection, but it doesn't work as well as a multiple. The advantage of paravertebral here is catheters. You can put a catheter in there and get 5 days of pain relief, and you can't do that with PECS blocks. Well, I certainly haven't read anything about it. Serratus blocks came out really poorly here, and they didn't impact on opiate consumption. And I do believe that serratus plane blocks do some good, but you have to very carefully match your cases, because you have to look what can a serratus plane block do, and it doesn't do. It won't help in superior and medial breast surgery. That's T1 area, and that's not blocking any of the T1 to T3 anterior perforators. It's going to do the lateral perforators. So that's not going to work, and you've got to look at your studies very carefully. PECS is not recommended for axillary clearance. They didn't say why, but I can guess why. Because you do a PECS 2, it goes into the axilla, and the surgeon says, stop doing this. It's making my life a misery. Here we've got some clinical suggestions. I've kept it sort of, not very hard, because there isn't a lot of that hard evidence for all of these techniques. But what you need if you want to implement this in your clinical practice is really good communication between surgeon and anesthetist, because you need to know exactly where your surgeon's operating, what segments he's going to be going for, if the axilla is involved or not. And if the axilla is involved, you immediately are being very careful about using a PECS 2 block, or leave it out completely. You try and do your fascial plane block at the level of the most important segments. So what we've seen in our practice is that where you put the needle in is what goes numb. So that segment is going to go numb. You can try hydrodissection, you can try higher volumes, you will get some spread, but where you stick the needle is definitely going to go numb if you're putting it in the right plane, and the rest is all bonus on top, but you can't rely on that. Don't inject near or into breast or axillary tissue, and the lymph drainage pathways, try to avoid them. On the right, you see a picture. You can see that if the surgery is in the lower lateral part of the breast, you should use serratus anterior plane. If you're in the upper medial part of the chest wall, as far as the breast is concerned, your anterior perforators T1 to 3 will be more important. So that a serratus anterior block is going to be less helpful there, and that might be skewing our evidence. So you can see the outer upper lobe is 55% of breast tumors are up in the upper outer lobe. And that's also where we're injecting our needle. Our needle track is going through that area, so be careful not to go through breast tissue. This is the cat amongst the pigeons. Now the lymph drainage, we're not really thinking about that. This is superficial lymph drainage, and this is deep lymph drainage of the breast tissue, which may contain tumor cells and may cause tumor spread. And this is something you have to speak to your surgeon with about very delicately. Try not to inject through these pathways. So you might have to modify your technique, but there's no evidence that there's been metastases due to local regional anesthetic techniques as of yet. The breast tissue is, however, very susceptible to spreading with fine needle aspirations. There have been quite a few studies done that show that you can get seeding with needle passes through the tumor. And so we do need to just think about this in the back of our heads and have an open discussion with the surgeon if it comes up. Good. How do they work? Fascial plane blocks. Well, I just wanted to mention, of course, that conventionally by blocking nerves is what we're trying to do primarily, but it's anesthetizing the fascia. It's producing a motor block, reducing muscle spasm, which is pulling on your site of surgery. There's local Beer's block type effect, which is possible by a vascular uptake of local anesthetic. Certainly the plasma levels of local anesthetic are quite high in sort of similar to lidocaine infusions. And there's also the possibility that we're damping down the local immune response in the area of the surgery. So there's lots of other technique options for fascial plane blocks to work other than blocking nerves. Right. So the $1 million question is, can I do an operation on the patient without a general anesthetic? So they're really sick and they not tolerating a general anesthetic. And there's a group in Berlin who's presented something on this, Timo Puschmann's group, and they do awake major breast surgery without general anesthesia. And they try to combine a neuraxial near block with a brachial plexus components. And that kind of makes sense. So they'll do an epidural paravertable block or an Erector Spinae block, and then they'll add the relevant brachial plexus components, either PECS blocks to knock out the serratus, the Pec Major, Pec Minor muscle, and the supraclavicular block, brachial plexus block to try and knock out the axillary innervation, which we know comes mostly from the brachial plexus. They use high volumes, they dilute it down a bit to get more spread. It takes time. This is not a quick and easy solution in a busy practice. This takes quite a bit of time to do. There are case reports out there using just serratus anterior plane and PECS 2 blocks for and not using neuraxial components for awake breast surgery, but these are single case reports and small surgical incisions, wide local excisions, but not major surgery. So what else? Mastectomy, yes, but you can do port placements, defibrillators. It's used for thoracotomy pain when neuraxial techniques are not available, and they use a serratus anterior plane block. It's been used for anterior rib fractures or flail chests, and it's quite a good idea for ambulatory breast surgery because you want to try to stay away from neuraxial blocks when you want to send somebody home in a couple of hours. So that's a good place to use it. Now, these are all small case reports, case series, and we need a lot more evidence to make clear indications for these operative interventions. And I'd be very careful to use it for all these as the primary source of regional anesthesia. I think epidurals are still the gold standard for many of these cases, but it's just a different option that's available to us. So that's my talk. I've got some film material at the end. I don't know how we're doing for time, Jeff.
I think it's probably best if we
PEC
answer some questions, if that's okay.
Yeah, okay. Perfect. the videos are self-explanatory. We can just let them run and we can start answering some questions if you like.
Yeah, that sounds great. Well, thank you so much, Alex. That was an excellent presentation. Some really excellent information from both you and Renee. I've got, we've got lots of questions, and folks, we're going to stick around for a few minutes past the hour just to make sure we get through most of these. I know that you've been patiently waiting to hear the answers. I'm going to answer a couple about rectus sheath quickly. Question about what local anesthetic we typically use. So oftentimes it'll be using good volumes, right? So 40 to 60 mils if we're doing bilateral. So I'll often use 0.2% ropivacaine plus some epinephrine in there. And I do consider using adjuvant sometimes. My adjuvant of choice is dexamethasone, which I'll add into the mix if I want to extend the sensory block a little bit longer. And we have been using some of in the US, some liposomal bupivacaine to, again, get a longer duration than just the regular local anesthetic. I'm going to get to catheters in a second because I want to hear the opinions of both Renee and Alex, and because we do make good use of catheters as well to really extend that duration. Medial or lateral, doesn't matter which direction you come in on the rectus sheath. We can do it parasagittal from below or above too. So that's a really easy block to come from any direction that. So if you have constraints with dressings, stomas, that sort of thing, you can really be flexible with it. There's a question about why not put the local on the anterior surface of the rectus sheath. And the answer to that is there is the tendinous intersections that give us the appearance of a six-pack on the abdominal wall. They tend to impede flow on that anterior surface, whereas the posterior surface is one big, long, continuous potential space, so that you get just better spread on the posterior surface. Right, so catheters. So we do catheters, and I'd love to hear about Renee's and Alex's opinion on best practices for putting catheters in the ESP block and for either PECS or Supratus. For rectus, just from my point of view, from rectus sheath, we'll put catheters in at the end of the case, bolus open that potential space, thread the catheter in, usually only about 3 to 4 centimeters, secure it. And with these fascial plane blocks, my experience has been that if you run a continuous infusion of, say, like 8 mils an hour, it's okay. But what you really need is that intermittent bolus to expand that space up back to where it was. So we'll run 0.2% ropivacaine, and then we'll set the pump to deliver a 20 mil bolus every 3 hours. So that's just between 6 and 7 mils per hour on each side. And we'll alternate the pumps. So they're every 90 minutes. So one side gets a bolus, one side gets a bolus. So we're not delivering a big mass of local anesthetic all at once. Renee and Alex, how about you guys with catheters and the blocks you talked about?
Well, for thoracic surgery, we do put in catheters in ESP block as well. We place them usually when the patient's asleep before the start of surgery, because it's easy, the surgeon is scrubbing in and we have some time to do it. I read one of the questions, do you put them in from caudal to cranial or cranial to caudal? Well, usually it's easier to do it from caudal to cranial, because the other way around, there's the back of the head that's a little bit in your way. So usually it's easier and more sterile, I think, to do it from caudal to cranial. We put in a catheter about 5 centimeters, the same as you, just as an epidural. I put it a little bit in, make sure it's how do you call it in English? You put a bandage on it or a tape that it's fixed, because you are scared that it will come loose when a patient moves a little. And then, well, we do a bolus at the start of surgery, and then after we ask the nurse. We don't have the fancy pumps you have, Jeff. I would like to have them. I think that will be a lot easier for the nurse. But they also do the boluses, because our experience is the same, that you need the bolus to keep the spread of the local anesthetic.
Yeah, agree. Alex, are you doing PECS and serratus catheters or PIP catheters?
No, but I don't think we will be able to do, or it would be possible to do a PECS 1, I think, with a catheter, but PECS 2 would be very challenging unless you come from laterally, and that will be in your surgical area if they're doing auxiliary work. So that's going to be difficult. It's going to be transmuscular. It's going to be high dislocation rates. However, serratus anterior, a deep serratus anterior plane block would be a really good candidate for a catheter. I'm actually waiting for some equipment to start doing that because I want to use multi-hole catheters for that. So the technique there is from inferior to superior, and you have the patient in the lateral position. And I often do the block like that anyway, because I'm not injecting through lymph territory. If I'm coming from inferiorly, and hydrodissect up from the 6th rib upwards. And I would often use 2 injection sites to get the spread up as far as about T3. But that would be an ideal place to put a catheter in. But a multi-hole catheter, so you're getting leakage over the about 5 to 10 centimeters of catheter, or you'd have to use your suggestion, which is really high pressure, high volume boluses to keep this reopening the space and then getting the required spread. But I think one technique is a multi-hole catheter here, which would be good.
Fair. All right, I'm going to press you on this. My sister shows up at your hospital for a mastectomy. What block are you going to do? ESP, serratus, PECS, Renee?
PECS 2.
I'm going to talk to the surgeon and the sister and sorry, ESP. First.
No, I would do a PECS 2. It's easier. You don't have to move the patient.
Alex, is your ESP decision based on what you were alluding to about transmission through potentially tissue that has tumor burden?
Yeah. I mean, seeding, look, if you think about seeding, if the tumor is in the tumor, these are tumor cells, right? And if they're in the tumor, it's going to be cut out. If it's in the lymph node, the surgeon's going to cut it out. If at the time of you putting a needle into that patient, there is a tumor cell sitting in a lymph duct on its way from the tumor to the lymph node, and you then disrupt that lymph duct and you get seeding of this tumor cell, then it's a problem. Now, that's a very, very specialized situation where you have to hit a very small duct. And at that point in time, there should be a tumor cell in it, which then doesn't spread up to the lymph node, which then doesn't get resected. So, it's very theoretical at the moment, but it's good because the surgeons will, if it's a good surgeon, they will ask you about that. What about seeding? Because they know that with FNABs, with fine needle aspiration biopsies, they're getting seeding. And so you've got to have an answer for that. And I think we should be, always upping the ante of the safety aspects of these blocks. And just because we haven't got a case report doesn't mean that that's not going to happen or can happen.
Renee, can you speak
so you can get there without going through these areas. From inferior is what I mentioned for this SAP blocks, the serratus anterior plane blocks, and you have to do your PEC blocks much higher up. So just below the clavicle, which I kind of like to do anyway, because I'm getting much closer to the origin of the medial lateral pectoral nerves, and I'm well away from breast tissue. And if I'm coming from medial to lateral, I'm not in the firing line for the lymph drainage, because I'll get deep to the muscle before I get underneath the area where the lymph.
Yeah, excellent. Renee, there's a question about the incidence of paravertebral spread that might cause either hypotension or confer an advantage for visceral coverage and visceral pain. Any thoughts on that? How often does ESP cover those things? I know it's a purported advantage of ESP, potential visceral coverage.
I have no idea, really. Sorry. And it happens. It's written in the article by Chin in Regional Anesthesia and Pain. We know why it happens. I have no idea how often it happens, because I don't know if you can really measure it well, how much spread there is, if it's clinically important or not. You don't see a lot of hypotension, so maybe only a few times, but I don't know the numbers.
That's been our experience too, is we don't seem to have the same hypotension as an epidural for sure, or even a paravertebral for that matter. Another question about ESP, what volumes are you using to get a certain number of levels? Is there a rule of thumb that you use, you know, so many milliliters to get 6 levels or something like that?
Yeah, well, if your patient is over 70 kilos and you use ropivacaine 0.5, you can use 40 milliliters, that's 200 milligrams. So that's safe for your local anesthetic toxicity dose range. And then you have large spread, because in thoracic surgery, you want just large spread for the beginning.
Mm-hmm.
But if your patient is really small or underweight, then we adjust first the concentration. And if they're really underweight or small, then we also adjust the volume. But we don't really have a rule of thumb for that, only that we don't want to go across the toxicity range boundaries. Yes.
For spine, are you doing these, a couple questions on spine?
Yes.
When are you doing it? Preoperatively, presumably. Are you doing both sides? Have you seen epidural spread with the spine ESPs?
For lumbar fusion surgery, yes, we do both sides. We usually do it at the start of surgery, before the start, so patient is asleep, then to prone position. One time in my talk I said supine position. It's not true, it's prone position. Prone. Sorry for that.
We knew what you meant.
Thank you. And so usually we do it when the surgeon scrubs in for surgery and we have time to do it. But sometimes the surgeon is in a rush, we want to be finished on time. And then they ask, will you please do it after surgery? So sometimes that works as well. So we do both.
Okay.
We don't really see any difference in large differences in opioid consumption. I think when you do it at the start, you want to see something like that. It has time to start working. Yeah, you can do both really.
For rib fractures.
Oh, sorry.
Go ahead.
Your last question was on, do you see epidural spread? We did not see any motor block because we were really paying attention to that together with the surgeon, of course, and we did not see any motor block yet.
Question about rib fractures. What's your preferred technique for, say, lateral or posterior rib fractures for a fascial plane block? We'll ignore epidural for now. So both of you.
Well, for me, if there are multiple rib fractures, I like to do, well, your epidural, I think, is your golden standard. But when your patient is old and has anticoagulants, it's easy to do an ESP block and put in a catheter.
Alex, what's your rib fracture block of choice?
Well, relevant to my talk, it's only the anterior fractures that come into question, but the Supratus anterior block would be the block for anterior rib fractures, which is, according to the literature out there, it's just case reports, so this is not high quality literature. That's what's been used, and they've almost always used it because they couldn't do an epidural for various reasons. So it's a default block, and it has worked very well in their descriptions. If you think about it anatomically, it doesn't make much sense because you're blocking the cutaneous nerves, the lateral perforators with a serratus anterior block, but you actually want to block the intercostal nerves themselves, and that's deeper, and that's responsible for the bony innervation of the ribs. So the mechanism of action would be one of the alternative mechanisms of actions in sense that it's going to relax the fascia and the serratus anterior muscle itself, so that you get less tension on the ribs and therefore less pain because of muscle spasm pulling on your fracture site. And if you're thinking of that as the mechanism, you probably should be doing an anterior serratus plane block, which is more likely to knock out the long thoracic nerve, which is running anterior or external to the muscle or deep the clavipectoral fascia. So you might want to change your block from a deep to a superficial one. We did these blocks on a volunteer, and we really tried to get the local anesthetic to spread retrograde or down to the intercostal nerve and see if we got anterior perforated block, but we didn't. So there's no spread from the deep serratus plane block retrograde, so to speak, along the nerve to the intercostal nerve itself. What we're thinking is happening with ESP blocks to a degree. If you're trying to get to the ventral branches, it just doesn't happen with the serratus anterior plane. There's too much resistance for the local anesthetic to get deep.
Mm-hmm. We've been using the superficial parasternal block for our sternotomies and finding good results. But then when we added the very high rectus sheath for those epigastric chest tubes, that's when we began to see just really good results, because I think that those chest tubes hurt more than the actual sternotomy itself. Have you guys experienced similar findings or heard similar
I have
stories?
not used that technique yet. I'm really enthusiastic to do it, but I hear patients complaining about thoracic drains, so I can imagine this is important.
There's a question about stomas on the abdominal wall and how to get around that with rectus sheath block. I would do that might impede the flow past the stoma if they're bringing bowel up through that rectus sheath. So I would probably do one on each side and sort of divide my dose and try to get coverage that way. Do either of you use adjuvants in your local anesthetics to prolong the duration?
Well, we don't. I read that it's possible. We usually use dexamethasone intravenously to prolong the blocks, but not anything else. Do you do it, Alexander?
No, I use Dex, but usually IV, and I do sometimes add noradrenaline to my serratus plane and PECS blocks simply because I've got often have very small patients. They're 50 kilograms. I'm putting in large volumes. I've got large surface areas, and I've got rapid uptake, and I've got. I'm not doing it because of length of block. I'm actually doing it to reduce the peak plasma level, with the idea that, the sympathectomy that you definitely get with these blocks, because the surgeon says you've done a block again, it's bleeding more than usual, would increase the uptake, and ropivacaine should cause a vasoconstriction, but the sympathectomy overrides that, and I'm trying to block that with a bit of noradrenaline, but that's for a different reason, so I'm not using adjuvants, no.
Got it. Renee, ESP blocks for pediatric surgery, how do you dose those? Any recommendations?
In my hospital, we don't really do any pediatric surgery, so I don't know the answer to that. I think most importantly is to acknowledge the toxicity levels, because this is an adjuvant. Usually it's part of, when you do single shot, it's part of multimodal analgesia regimens. So you want to be on the safe side for sure. Yeah.
And then another question about ESPs for abdominal surgery. So are there cases where you'd want to do ESP in place of, say, a tap block or a rectus sheath? Or is it are you finding your better successes are more thoracic and with spine?
Yeah, with spine for sure, because you always block the dorsal parts of your spinal nerves. So that's easiest. And for abdominal surgery, I don't really think there are studies that compare those three techniques yet.
Mm-hmm. Yeah, we've used it in a variety of settings. Spine has been a real win. That was an easy one to convince the surgeons that this was a good thing to do. And of course, they were a little reluctant, as surgeons are sometimes when you're poking around near their surgical field. But we saw instant benefits with that. And I think you're right. I think it's because if you're going to get anything with ESP, it's that dorsal ramus that comes right off immediately. So That's been good. Rib fractures, we touched on that. How far
Can
from
I
line
ask
do
a
you
question
inject?
for Renee?
Oh, yeah. Yeah. Go ahead, Alex.
Do you for the ESP, I mean, if you have the conundrum, do you try to block a nerve, or are you doing something else, relaxing muscle spasm or whatever? Are you trying to adjust your injection point closer to the dorsal root perforation point? It comes out through the foramina. Are you trying to get along the transverse process slightly more medially, so that you're getting closer to where it's perforating, or are you strictly staying out on the outer edge of the transverse process and getting the having to rely on a bit further, spread for the local anesthetic to get to the dorsal root?
Well, in spine surgery, we just go for the tip of the transverse process, and then sometimes you touch it, and then there you are. And in thoracic, it's a little bit different. There you use a large volume, and I think the large volume is more it's important in the spread of the block, maybe more or equal than where you place the needle. But usually we just go for the tip of the transverse process. Do you do it differently, or you maybe, Jeff?
Yeah, we aim for the lateral tip as opposed to getting closer to the lamina. I mean, at some point it becomes a retrolaminar block, which I'm not sure there's much difference in terms of how it's actually working. But I think it's in terms of imaging, especially in the lumbar area, imaging the tips, which are slightly more shallow than the lamina, seems to be easier for us. Here's a good question this is from Cassie Andrews in Australia. With ESP done preoperatively, what do you think is the length of time that it takes to work? So 30 to 40 minutes, is it working with enough time that you can take advantage of it to lower your intraoperative anesthetic requirement or opioid requirement? Or is it really more for post-operative pain? Do you have thoughts on that?
Well, we have not studied this yet in real numbers, but my gut feeling says it takes some time to start working, maybe more than 15 minutes. You don't really see that your patient need less opioids if you start it at the start. I think it's because it's really part of multimodal analgesia, so you need everything. So I don't think the differences in intraoperative analgesia are that large. How is your experience in that?
Similar. I mean, it's hard. I think we see most of the difference in the recovery room.
Yeah.
And those, especially with those, I think it's a softer landing from than if they didn't have it preoperatively. And we haven't done a lot of them sort of right before emergence, so it's hard to compare. Here's one thing we did observe. We did a cadaver study looking at the time it took to actually reach its peak distribution, and it's minutes. It takes a while. So you inject that 30 mils in the ESP plane, and then do fluoroscopy, and it takes about 15 to 20 minutes before it finally reaches its out. So that's a good little, I think it's been a helpful observation for us in terms of understanding you can't just do this blog and expect it to work immediately. How about lots of interest in ESP, a lot of ESP questions. You got your work cut out for you here.
Yeah.
Do you think, are you using it for hip replacement? Someone's asking, is that an effective application of ESP?
We don't use it for hip replacement. I think we use Plane blocks, other blocks like that much more often. So I don't have any advice on that.
How about you, Alex? Are you Are you doing it for anything unusual?
No, I'm not using it for hip or abdominal surgery at the moment. I just haven't seen the ventral spread as being adequate enough, or at least I don't understand why the block will be working if it's not blocking the nerve. It's different for spinal surgery, because you're definitely going to get much better response. You're also anesthetizing the nerves, the muscles, the erector spinae muscles themselves. But we use Peng blocks and high femoral blocks for hips, not erector spinae.
Yeah, it's interesting. It's like people describe using the QL block as well for hips, and we haven't done that either. And I wonder if it's because you're getting T12 and L1, and maybe that iliohypogastric coverage on the skin on the side is helping to contribute to some analgesia. But I in our practice, I think we go to a fascia iliaca or a Peng first over an ESP or a QL. So I think we're at 20 minutes past the hour, and I think we've gotten through most of the questions. I apologize if we didn't get to, I know we didn't get to all the questions, but hopefully there'll be a forum in which we can answer these offline afterwards. I know there's been a lot of interest, and obviously Renee and Alex did an amazing job presenting their topics, so not surprising. I want to once again thank ESRA, and I want to thank Pajunk for putting this together and allowing us to communicate some of our ideas and thoughts and passions for regional anesthesia to everybody. And thank you to all of you who joined us. This is an amazing interaction. We had a lot of people on this call. So thank you very much, and we'll see you next time.